Now we have, the most illustrious panel here. You could probably cover huge bases in terms of the treatment of patients with immuno-oncology agents, both in the clinic and those in development. And so, an opportunity now to ask you questions to the panel. And what I'm going to do, I'm going to warn you, I'm going to come around with this microphone and actually field questions from you. So we're going to extract some decent questions. So please, all of you, think of a question to ask, and we'll see how many questions we can get to. So I don't know if you want to introduce yourselves on the panel, or shall I walk you through?
So Ryan Sullivan, I'm a medical oncologist at Mass General Hospital focusing on melanoma and our phase 1 specific focus in immunotherapy.
And you already heard who I was.
I'm Kipp Weiskopf. I'm one of the clinical fellows in hematology and oncology at Dana-Farber and MGH, and my background is in targeting myeloid cells as effectors of cancer immunotherapy.
And you guys are sick of hearing from me by now.
No. So firstly, Keith gave a fantastic talk. Any burning questions for Keith? And I shall bring the microphone there, and then we can weave that into this discussion.
Thank you for a wonderful talk. I was actually wondering about your thoughts on recent publications that are starting to emerge now, first from Nick Haning's group, that have identified a subset of progenitor CD8 T cells that have stem cell-like properties that express high levels of the gene TCF7 that encodes the transcription factor TCF1. And as we're sort of beginning to understand how PD-1 might actually work, are you planning on leveraging these insights to use this potential population as a biomarker for patients that might selectively respond to PD-1 therapy? I'm sure that
so since I'm only a middle author on the Cell paper that we published last fall, I will use the opportunity to say that paper validates our paper. I skipped over the details because I didn't want to show 5 slides from that, just that one story. But basically, the activated T cell, or the T cell population that is associated with response had multiple transcriptional features, but the single feature that seemed to be able to capture the population was TCF7. So if you haven't looked at the data, you'll pull that out yourself. So we then referred to that as the TCF7 positive population, and we scored the good versus the bad became TCF7 positive versus TCF7 negative. And if you simply had a ratio of TCF7 positive over negative that was greater than 1, then your likelihood of response was vastly greater than the other ratio. So it's exactly as the Haning paper seems to suggest. This appears to be this sort of stem-like population that has proliferative capacity, and that is perhaps what's being unleashed by PD-1 antibody therapy. And if you don't have that population, yet you have CD8s in the tumor that can't expand, and particularly if they have markers of exhaustion, which our paper suggests that those TCF7 negative cells commonly do, then they might be there, but they're not going to do anything in response to PD-1, or if they do anything, they do it for a day and then run out of gas and peter out. So the idea that if you have either that pool or you don't have any CD8s present in the tumor at all, that you're effectively out of the running is, I think, the emerging observation. If it's all about having this progenitor pool in the tumor at baseline, then the question becomes what therapies will make that happen, right? So we'll set the stage. I mean, this is what all the PD-1 plus X trials have been kind of hoping for, that X is an agent that actually, sets the stage for PD-1 response. This gives us, I think, an idea of what stage setting really means. And following these papers, I think, at least in our studies, it gives us a fairly obvious question that we would like to address with serial biopsies of investigational agents alone to understand, do they actually create an infiltration or increased representation of that cell population as a monotherapy effect. Even if they don't cause tumors to shrink, then if you were to add a PD-1 antibody, that would be more likely to induce response is the obvious hypothesis. So we may need who knows how many therapies to try to produce that effect in various tumor types, and some of those may be other immune mechanisms, some might be direct tumor cell targeted mechanisms, as I was alluding to in my talk.
Great. I always thought that the coincidence, really, that you have a human study looking at, and they find 1 or 2 markers that find that T cell, and then you have a murine study from Nick Haning's group that identify the same the same transcription factor, which actually links to the stem cell memory population of T cells, was really quite something. And it would be difficult to actually engineer it if you were trying to combine it into the same publication.
That's right.
So, any further questions? Yes, we've got. I'll go to you first. You put your hand up first, and then to the second person.
Thank you. It's regarding tumor mutational burden. Do you think should be different, the threshold should be different depending on the tumor type? For example, 10 mutations per megabase in melanoma is low, but in breast cancer patient is high. So do you think it would be different?
Well, I don't know about whether it should be different. I think it will end up being different is my guess, but I would say that probably for almost every type of biomarker we're talking about. Even this discussion about TCF7 positive T cells, it could be that in certain tumors, if you have enough TCF7 positive T cells and you don't have a lot of headwind coming from suppressor populations in the tumor microenvironment, that a ratio, as I was suggesting, of TCF7 positive negative of 1 or higher is sufficient. There could be other tumors that have a lot of myeloid cells present, creating a lot of headwind for whatever T cell population pre-exists, where you may need a ratio of 4. And so I totally embrace that point that tumor mutation burden as a single measure is likely not to have a universal cut point across tumors. But I would repeat that same point for almost every other marker that we're looking at these days. So the flip side, of course, is that there could be clusters of tumors that actually have the same features in terms of those signatures. So maybe we have 3 or 4 where you could come up with one TMB cut point, overlay on top of that 1 or 2 immune features, and that's a usable package for that set of tumors, but in another subset of tumors different. So I don't know that it's going to need to be totally personalized by tumor type.
I would add, though, that right now TMB is such a crude estimate, right? Or just total number of mutations. But I think, as Xin Gao had pointed out, there are some tumors like renal cell where the TMB is not that high. But if you start delving into it, yet those tumors have these frame shift mutations, right? And so a single nucleotide variant may not count the same as a frame shift where the rest of the sequence is going to be very different and likely to be much more immunogenic, right? So I think adding granularity to what we mean by, what we're counting in TMB is also going to come into focus in the coming years.
Hello, my question is for Dr. Gainor. It's about the clinical case we discussed earlier regarding the use of other anti-PD-L1, because in the therapeutic options, we talked about pembrolizumab, and I was wondering, in your clinical practice daily, what's the place for the others like durvalumab or Tecentriq, for example?
Yeah, so in terms of, so your question is, what's the role of the other PD-1 and PD-L1 inhibitors?
Because I'm medical oncologist from Morocco,
okay.
And there we just got the Tecentriq, and we still do not got Imfinzi, for example.
Okay.
So how do you choose the
Right. Yeah, so it's a good question. So in lung cancer, things have changed very dramatically over the last 4 years, and I would say the approvals have gone from the second line setting to the first line setting to the then starting to be stage 3 setting. And the agents that are approved in those indications are somewhat different. So in the second line setting, that's where we have the most approvals. That's where Pembro, Nivo, and Atezo are approved. In the first line, only Pembro monotherapy or Pembro or Atezo with chemo. And in the stage 3 setting is Durva. And so in the first line setting, making really the decision based upon PD-L1 status. So this is a little bit different than in the melanoma setting, right, where we are using PD-L1 status. And then what's the patient's clinical condition? Do they need a response because they're in visceral crisis, or can we get by with monotherapy?
Here's another question. This question is to Dr. Flaherty. it's very interesting to see the relationship of depth of response and durability of outcome. Has there been any study to evaluate the speed to respond and the durability?
Not that I've seen published. We began looking at that. So we're doing a study right now which involves, next generation biomarkers, but going back to the clinical data and radiographic outcomes over time, and began asking exactly that question. And it doesn't look like speed of response is particularly important. It's the settling out point. That's, in other words, maximal depth of response, not necessarily depth by a certain deadline, but maximal depth of response, it seems to matter. One of the points that I anguish about a bit in this regard is that we know so little about organ site specific tumor biology / immunobiology. And one thing that we've observed in melanoma is that lung metastases will regress more deeply than liver metastases, for example. And we're not the only ones who've described that, but we definitely see it in our data. And one wonders, is that real or is that artifact? Is it really a consequence of a different immune microenvironment and ability to respond to PD-1 antibody in lung versus liver? Or is it a quote-unquote architecture of tumor thing where the scaffolding, extracellular matrix and so on in the two environments is fundamentally different? And what I mean by that is perhaps the number of tumor cells being killed is identical, but the ability of the tumor to actually collapse radiographically might be different. If that's the answer, that's not very interesting. What I mean by that is that's just a radiographic artifact, and we just have to figure out how to account for that and how we assess response and guide patients in terms of their prognosis after initial response. But it's clear that in the indications in which PD-1 antibodies are used alone, that maximal response is achieved somewhere between 6 to 12 months, roughly, in a cohort of patients. And it's thereafter that you begin to worry about patients who still have a significant amount of viable tumor, and which is the point that I was alluding to there. And there's studies that are now ongoing in terms of how to think about assessing those patients with functional scans, biopsies, rather than just wait for tumors to progress, assess the situation, and then attempt to intervene for residual tumors.
Hello. So I have a question for all of you. So I'm a pathologist. I'm reading the PD-L1 every day on the biopsy specimens. So I'm so I come to this meeting trying to take home some message or wisdom to how to interpret my observation. So the more I see, the more I get confused, not as excited as the beginning. So the reason is, so from today's lectures, you all give me an impression is, across the board, actually the response is irrelevant to the PD-L1 levels. But however, every oncologist ordered that test. And not only on those FDA approved those drugs, also on those non-FDA approved. For example, recently they approved the triple-negative breast cancer, so it's to use the Tecentriq SP142 that clones. But on the other hand, the oncologist ordered they order PD-L1 for those ER/PR positive. So it is not fit for the requirement for that FDA approved. So what kind of antibody we should use? How should we interpret what we observed? So I want some wisdom from you to take home.
So maybe I'll just add one I'll start and then I'll throw it down. Because I would say in lung cancer, it's not that it's irrelevant. It's actually an important biomarker, though very imperfect. And we still use it because we know in randomized phase 3 studies that at the 50% cut point, there's an improvement in survival compared to chemotherapy. When a 25% cut point has been looked at, 5% cut point has been looked at, those were negative studies. It does look like there is something about that 50% cut point that is driving benefit, but it doesn't, discriminate well. It's still imperfect. So it takes a 20% response rate in an unselected group and improves that to 40%. Now that's enough to beat chemotherapy, but it's still not like having a molecular alteration where I can use a targeted therapy, right? Where that's as much of a home run as we get in oncology, knowing where we have BRAF or EGFR alteration, we know those patients are likely going to respond to targeted therapy. PD-L1 is not like that, which is why we're focused on all these other biomarkers. In terms of the harmonization, I think you're right in that the challenge is that across all different tumors, you're getting different scoring cutoffs, different antibodies. I think it's a major challenge in the field. In lung cancer, the way we've approached that is academics coming together for harmonization efforts, looking at concordance across antibodies, showing that if you use one, it's pretty similar to the other.
It was recently reported that lung cancer tumors with KRAS mutation and TP3 wild type do not respond to pembrolizumab, and also in another report, MDM amplification may drive resistance to pembrolizumab. Do you have any new insight?
Yeah, so what we've come to recognize is that KRAS mutant lung cancer isn't just one molecular subset. There are actually 3 distinct subsets within that. I would argue that the most relevant, clinically relevant, is actually the KRAS plus LKB1. In fact, Keith showed some of the data from our JCO paper showing that LKB1 is actually a marker of those patients simply don't respond to checkpoint inhibitors. It's really interesting because those tumors tend to be TMB high, yet don't respond. So in a multi-center analysis, the response rate for STK11, aka LKB1, was 0 to 10%. It's commonly co-mutated with KRAS, which is why I bring it up. But even independent of KRAS, very low response rate, less than 10%. So if you break apart KRAS into KRAS LKB1, very low response rate. KRAS TP53, very high response rate. So it's really distinguished by LKB1. MDM2? Yeah, so MDM2 in lung cancer has been, MDM2 amplification was associated with this so-called hyperprogression, which, I think there's been a lot of talk for those of you who have heard of this term, hyperprogression. Basically, that the growth kinetics of the tumor actually increase in response to checkpoint. I'll be curious what my colleagues think. My initial impression of that has been it's even when chemotherapy doesn't cause an objective response, it can cause still stasis. Whereas when a checkpoint inhibitor doesn't work, you're just watching the natural history of the disease. The cancer is just blowing up. Recently, though, there's been a paper in PNAS, trying to show some mechanistic rationale for hyperprogression and thinking that it plays a role in T regulatory cells, and that may be driving the hyperprogression. I think it's still very much early.
So I just wanted to bring Kipp in, actually, because we've heard a lot about T cells and antigens, but the myeloid cells have been something we haven't talked about. I mean, we've had some recent, clinical trials have read out on IDO inhibitors, and they've been obviously somewhat disappointing, but it feels like just the beginning of the myeloid story. Could you sort of give us a little bit more granularity?
Yeah, I'd love to. It's my favorite topic to talk about. So coming back to the question of what do we do with PD-1 staining or PD-L1 staining in the tumor, when we look at the cells being stained with PD-L1 antibodies, when we're looking histologically, we often see that it's not only the tumor cells, but it's also macrophages and potentially other myeloid cells within the tumor microenvironment that are staining positive. And so this raises a lot of interesting biological questions. What are the myeloid cells doing within the tumor microenvironment? Are they actually contributing to the growth of the tumor, or is there a way to augment their ability to attack and eliminate the tumors? And there's definitely emerging evidence now that even things that block PD-1 or PD-L1 can directly stimulate tumor-associated macrophages to attack cancer cells, and attack cancer cells in different models. And so I think that's something that's a little bit more provocative and somewhat kind of flips the perspective on who the true effector cells are in response to PD-1 and PD-L1 blockade in a T-cell centric world. But it's definitely becoming more apparent that in many different cases, there are many macrophages that infiltrate into tumors. Across many different tumor types, they often are the most common immune cell that infiltrates into tumors. And so there have been a number of different groups and a number of different efforts looking in clinical trials and looking at the underlying biology of how we can either augment the effects of macrophages or other myeloid cells, or how we can deplete them for the benefit of patients. And so there have been a few different efforts looking at this approach. One of the more promising that I've done my own work on has been looking at the CD47 SIRP-alpha interaction. This is something that we've described as a myeloid immune checkpoint or a macrophage immune checkpoint. And we believe that it behaves somewhat analogously to the PD-1, PD-L1 axis, just like that does for T cells relating to antigen-presenting cells or cancer cells. But the CD47 SIRP-alpha axis acts on macrophages and myeloid cells within the tumor microenvironment in their interactions with cancer. And so CD47 is highly expressed on many different types of cancers, and the receptor SIRP-alpha is an inhibitory receptor that's expressed on macrophages and other myeloid cells. We found that antibody therapies that disrupt this interaction, just like anti-PD-1 or PD-L1 antibodies, the antibodies to CD47 or antibodies to SIRP-alpha can lower the threshold for macrophage phagocytosis of cancer cells. And there are clinical trials that are ongoing that have provided some initial proof of concept of this approach and this strategy. And definitely something that I think is going to be more apparent in emerging as another novel immunotherapeutic approach and strategy.
Great. And maybe I can follow up to Ryan, actually, a question. I don't know the answer to this, but...
I hope I do.
He does. He always knows the answer. So, what we've seen with PD-1 is quite a toxic drug. And my prediction would have been, if anything was going to synergize with PD-1, it would have been targeted therapies. Therapies that effectively avoid immune cell suppression. So the surprise for me is actually that the winners, in terms of what you pair with PD-1, is your standard chemotherapy agents. And as an immunologist, these things are not kind on immune cells. And so you've got this kind of, why is it that the targeted agents are not synergizing more with the immune response, and yet the chemo standard therapies are?
Yeah, it may. There's clearly some evidence to support targeted therapies, but one of the challenges is toxicity. And so it may be that when you clinically give, say, BRAF targeted therapy or EGFR targeted therapy or ALK targeted therapy with a PD-1 or PD-L1 inhibitor, it's not so much that you can't have synergy, like that you wouldn't have synergy, but that because the toxicity is higher, it's hard to have synergy, and that you have to do things to counteract either the toxicity or you just have to stop using that. Whereas chemotherapy, some of the immune suppressive parts of chemotherapy may be useful in combining with anti-PD-1 antibody therapy. And then obviously there are various effects on the immune microenvironment of chemotherapy that wouldn't necessarily have been intuitive, but yet also may help to either they have effects on myeloid or T regulatory cells or other elements that just end up being a good therapy, or it may just be that they kill cells, and killing cells in combination with PD-1 inhibitor is good if you can tolerate it.
So maybe you're killing the cells in a way that's destructive or something.
Yeah.
So I'm mindful of time because we're trying to keep on schedule. I don't want to ease into your time, Ryan. So I think probably we should stop there and just sort of thank the panel for answering the question.
Thanks for coming.